Good morning and welcome. On behalf of the Ohio Department of Medicaid, we welcome you to today's Next Generation Pharmacy Program Pharmacy Reimbursement Presentation. Today's session is our third session of the Pharmacy Stakeholder Webinar Series. And at this time, I'd like to turn things over to Stephen Alexander, who will be the session facilitator for a brief overview regarding the question and answer session that will take place at the end of the presentation, time permitting. Stephen?
Hi, everyone. Thanks, Sean. As Sean said, we are going to try to take questions at the end, time permitting. So we do have 60 minutes set aside for this webinar, and we have a lot to get through. So to make things as quick as possible, once we get to the end, during the webinar, you can ask your question at any time. Just go to the Go to Webinar question function. And then at the end, we'll have a brief Q&A where we'll go through as many questions as possible. Please, in your question, add in your name if you can. And any question that we don't get to, we will respond in writing after the webinar as soon as we possibly can. So with that, Sean, I'll kick it back over to you.
Thank you, Stephen. So for today, we have 4 total presenters, and my name is Sean Eckert. I'm the Pharmacy Director for the Ohio Department of Medicaid. I'm also joined today by Maureen Corcoran, the Director of Ohio Medicaid, AJ Summers, Senior Manager from Myers & Stauffer, serving as the Pharmacy Pricing and Audit Consultant, and Dave Hartzell, Clinical Account Manager with Gainwell Technologies, and they are serving as the Single PBM vendor. At this time, I'd like to turn things over to Director Corcoran for a welcome and introduction. Director?
Thank you, Sean, and thanks AJ and Dave for joining us today. Next slide. So I want to just set the stage a little bit, brief history. Maybe most important from this slide is, as they say, you know, those who don't study or recall their history are destined to repeat it. And clearly, next slide, our our history on this is important to why we are here today. The single PBM was mandated as a part of House Bill 166 in the budget before the last one. And it was to address concerns that we now understand more fully are concerns across the nation. Lack of transparency, the disconnect between pharmacy reimbursement and overall cost to the program, conflicts of interest, sort of hidden or not well understood financial incentives and dynamics, and the impact of reductions in pharmacy reimbursement, including at the back end, and how that affects access to care, particularly in rural areas or for individuals in our program who have particular healthcare needs. Next slide. So further, how did we get here? Well, the key issues that reflect or sort of constitute where we are today are the spread pricing. The pharmacy benefit management program had very little transparency or understanding about what was in it, all shrouded in secrecy, charging unnecessary fees, contracts that contained effective rate contracts and clawbacks, and certainly dynamics, as I mentioned, and incentives that were driven more by patient mix or drug mix rather that contribute to pharmacy deserts or have disproportionate impact on those with who we serve who have more significant healthcare needs. Next slide. So where we are today with this new program, and we are trying to do 2 things: to give you an update on the essential questions that we know are important to your business consideration as pharmacists, dispensing fee, the acquisition costs, etc. But we're also going to try to be very open with you about the reasons why we've made certain changes and what the policy, what that is intended to reflect from a policy point of view. So this new approach includes no spread pricing, no clawbacks, no hidden fees, There's no hidden incentives or hydraulics to steer patients based on financial considerations. It prioritizes consumer access as our highest priority. It is budget neutral, as is necessitated because of the budget constraints and appropriations that we operate within. And it is also based on actual evidence-based Ohio data, which will be continuously monitored and adjusted in order to take into account changes in pricing as well as changes in the market considerations. So I want to add my thanks for your taking the time today and turn it back over to Sean.
Thank you, Director. Next slide, please. So as a reminder, at the beginning of all of the presentations that we do, we like to remind everyone of the Next Generation Medicaid Program mission statement, which is to focus on the individual rather than the business of managed care, because we want to do better for the people that we serve. It's important to note that everything that we do at Ohio Medicaid is really driven by this mission statement. And how we do better for the people that we serve is by focusing on the individual. We want to be a national leader in healthcare innovation. We want to be a good partner for providers. We want to provide fair and transparent reimbursement for providers. And we also want to improve health outcomes, leading to a healthier Ohio. Next slide. So just to get things started, a brief abbreviation summary here. For many of you, you're very familiar with these already, but we just like to provide these for reference. The key ones today are SPBM, which is the Single Pharmacy Benefit Manager, PPAC, which is the Pharmacy Pricing and Audit Consultant, and then we have several pricing metric abbreviations that we'll be using, particularly OAAC, which is the Ohio Average Acquisition Cost, WAC, or WAC, which is Wholesale Acquisition Cost, and as well NADAC, which is the National Average Drug Acquisition Cost. Next slide. So today's presentation, we've broken it out into four sections. The first section will be delivered by the Department of Medicaid, which will provide an overview of the Next Gen Pharmacy program, as well as the reimbursement structure. We'll talk about the dispensing fee philosophy and methodology that we've used to craft the new SPBM dispensing fees. We'll talk about the tier scoring methodology, which is an important mechanism by which most pharmacies within the program will be scored. We'll talk then about the specific dispensing fee tiers and rates under the new program, as well as some operational considerations around how the dispensing fees will be managed going forward. At that point, I'll turn things over to Myers and Stauffer for them to discuss the OAAC in more detail, as what's been provided in previous presentations, with specifics about OAAC rates, the rate review process, and other operational considerations with the AAC program. And then lastly, we'll turn it to Gainwell Technologies for a brief contracting update and some next steps with Gainwell. And then lastly, we will do the question and answer session, time permitting. Next slide. So as far as SPBM and managed care is concerned, ODM is really building the next generation of managed care, and that integrates components such as SPBM into that structure. The objectives for SPBM are aligned with the goals of the Next Gen program. And those objectives and goals are putting the individual first, personalizing the care experience for members, helping providers deliver better care through reduced administrative burden, achieving program transparency and accountability, ensuring fairness and equity in reimbursement structure, improving wellness and health outcomes of our members, as well as supporting children and adults with complex needs. Next slide. A brief overview of the current managed care pharmacy benefits. So the current landscape Right now, we see typically AWP, or average wholesale price based pricing. We also have heard complicated contracts that are aggregating multiple lines of business, so that aggregate Medicaid lines of business with other lines such as commercial. It's not transparent. Some of these contracts may contain effective rate contracting provisions and associated clawbacks. There's also unnecessary and burdensome fees in the contract, such as network transmission fees that are charged to pharmacy providers just for doing business with the current PBMs. And pharmacy reimbursement's driven a lot by what we would call an ingredient cost arbitrage method. So that's highly dependent on patient mix and drug mix. And it's just not a fair reimbursement strategy moving forward for our providers. Most importantly, in an analysis, and we looked at over 38 million claims from the managed care plans, we observed an average MCO PBM dispensing fee of just 73 cents under the current program. Next slide. This slide overviews the ingredient cost methodology that will be used for SPBM ingredient cost. It's broken down into some buckets. We've got non-specialty, specialty, clotting factor, and 340B. Generally speaking, the reimbursement methodology for ingredient cost consists of a lesser of all methodology, where all includes the Ohio average acquisition cost, the national average drug acquisition cost, WAC, as well as the usual and customary, also known as the cash price for members. There are some exceptions to that. One notable exception is for clotting factor. We will be using the OAAC rate plus a clotting factor dispensing fee, or the usual and customary. And then for 340B, 340B covered entities will be reimbursed in accordance with Ohio Revised Code 5167.123, which specifies that we will be paying NADAC. And if there is not a NADAC available for that, they'll be paid at WAC plus the dispensing fee. Also important to note on this slide, you'll notice that we have special dispensing fees for both specialty and clotting factor. And we'll talk more in detail about that later, but that is to reimburse those providers for the extra requirements that are associated with filling those types of prescriptions, as well as extra overhead costs with those pharmacy operations. Next slide. This slide is intended to illustrate that even though we are using a lesser of all methodology, we want to be straightforward about how these rates all interplay together. And so what you see on this slide is based upon some fiscal projections that was performed. And these percentages are the expected percentage of claims that will be, that are projected to be reimbursed at each of the pricing metrics listed in the chart. So from this chart, you'll notice that brand drug products are projected to be paid, at least 64% of claims are projected to be paid at the NADAC rate. 21% of brand drug product claims are expected to be paid at OAAC, and 10% of brand drug product claims are expected to be paid at WAC. For generics, OAAC will be the majority metric that we project will be utilized to pay claims at 81% of claims, with 7% of generic claims paid at NADAC and approximately 4% at WAC. And then for specialty drug products, typically specialty drug products do not have NADAC-based pricing. And so for specialty drug products, we anticipate approximately 60% of those claims would be paid at OAAC and 38% at WAC. So still a significant amount of rates or claims that are expected to pay at WAC. It's important to note that this was based on fiscal projections that the department performed, and these were a point-in-time analysis, and so they are approximate projections of the claims payment methodology. An individual's provider experience may vary with the program, And as the program changes, these percentages are subject to change, but we want to be straightforward with providers in terms of what metric will be used approximately what proportion of the time in accordance with that lesser of ingredient cost pricing methodology. Next slide. In terms of dispensing fee structure, dispensing fees for medications under the pharmacy benefit will be determined both at the provider and also at the medication level. ODM also recognizes that specialty pharmacies typically incur higher costs. This is due to specific accreditation requirements, shipping and handling requirements, staff training, as well as more extensive patient counseling and clinical considerations, as well as regulatory requirements. Owing to that, we do allow for an add-on specialty medication dispensing fee. This is in addition to the standard dispensing fee, or what we term the base dispensing fees. These are based upon provider under a 3-tiered system. Specialty pharmacy providers, as we've indicated before, will be automatically placed in Tier C, which is the highest tier under the program, owing to those increased overhead costs. Really, the critical consideration there is maintaining access for members, particularly for specialty medications, owing to limited distribution networks of many of those medications, as well as the serious and possibly rare conditions that those medications treat. In terms of that specialty medication dispensing fee, that add-on specialty dispensing fee will be added to the base dispensing fee only for specialty medications as defined by ODM. In addition, we have a clotting factor dispensing fee that is paid to qualified pharmacies that dispense clotting factor products. And that is also added to the base dispensing fee to reimburse those providers for even more significant overhead costs and operational costs that are associated with dispensing clotting factor product. And again, the critical consideration there is maintaining access for members with bleeding disorders. Next slide. Regarding some dispensing fee considerations, so in crafting the dispensing fee structure, ODM reviewed the following documents and data points in terms of setting the dispensing fees under the new program. The first was the PPAC fiscal analysis that was performed by Myers and Stauffer. And that fiscal analysis was used to project the Ohio average acquisition cost rates to assist in determining the budgetary impact of the new dispensing fee structure. We also reviewed provider level impacts in an attempt to minimize provider level impacts to the greatest extent possible, especially adverse impacts to providers. We also understand that the use of an AAC-based ingredient cost may have differential impacts on small versus large providers. There are differences in how small and large providers contract for purchasing medications, and ODM does understand those differences and does try to account for that in the dispensing fee methodology. We also had a desire to use familiar and accepted metrics for setting dispensing fees. And so we really looked to, first of all, the supplemental or tiered dispensing fee methodology that we currently pay out for managed care claims on a quarterly basis. We also looked to the fee-for-service dispensing fee methodology for guidance as well. And then lastly, we looked to the cost of dispensing survey that's performed every 2 years, and that's also performed by Myers and Stauffer. That was last updated in 2020. And that is due to, for an update this fall. It's performed in even number years. And while we're talking about the cost of dispensing survey, I just want to underscore the true importance for all pharmacy providers to participate in the cost of dispensing survey, because the cost of dispensing survey data points that we collect will be used to assist in setting the SPBM dispensing fee tiers. And so it's a very important mechanism for the department to be able to collect data. And so it's very important that all providers participate in the cost of dispensing survey every 2 years. And another important note is that dispensing fees under the SPBM program the rates that we're about to discuss today in no way impact the fee-for-service program. Those dispensing fee rates will remain as specified in Ohio Administrative Code 5160-9-05. Next slide. Some additional philosophy about the dispensing fee, and this is kind of the general overview of what we're trying to accomplish with the dispensing fee. First of all, fiscally responsible, budget neutral for the state. Again, as the director alluded to, we have to operate within the appropriations that are allotted to the department. We also, through the dispensing fees, want to encourage providers to locate in pharmacy deserts. Really, as we build the next generation program with Gainwell and with Myers and Stauffer, the issue of access is of critical importance to us. And so we want to encourage providers to locate in those areas where there may not be as dense distribution of pharmacies. And we attempt to do that through the dispensing fee methodology that we're going to discuss. We also want to adequately reimburse pharmacies for the services provided. We want to minimize provider impact versus the current structure, especially adverse impacts. We want to be fair to providers. And part of being fair is recognizing that low volume providers may not be able to purchase drugs at the same rate as the large nationals. And we also want to appreciate that providers with high Medicaid volume and the impact that that can have on a business. And so we've taken these factors into consideration within the dispensing fee structure. Also, overwhelmingly, the input from stakeholders is in support of a tiered structure where there are tiers based upon various metrics. We also wanted to improve the fee-for-service style dispensing fees. Current fee-for-service style dispensing fees are only based upon total pharmacy volume. And so we want to try to take that a step further to more accurately reimburse providers, not only for their true cost of dispensing, but also with those unique considerations of their business in terms of the proportion of Medicaid volume and the proportion of members that they serve that are Ohio Medicaid members. And then lastly, and very importantly to the department, is the issue of value-based reimbursement. And value-based reimbursement will be a future consideration for the program. The main objective right now is implementation of the SPBM, but in the future, look for more information about value-based reimbursements and what those will look like under the program as well. So in addition to these dispensing fees. Next slide. So as far as the tier scoring methodology, so our dispensing fee tiers are based upon two components. The first component is the total pharmacy script volume, and this is the same metric that we use for the fee-for-service program. And this is total pharmacy script volume on an annual basis by pharmacy. We have two cutoff points. One is at 50,000 prescriptions per year. The other is at 75,000 prescriptions per year. So you'll notice that as prescription volume goes up, the point values go down. And that is due to information that we have from our cost of dispensing survey that shows as prescription volume goes up, the average cost to dispense a medication goes down due to economies of scale and business efficiencies. One of the reasons why we have higher points at the lower end of the range is, again, owing to that issue of pharmacy deserts. We know that pharmacy deserts typically are in more rural areas of the state, but they can also exist in areas of the state that have a higher population of Medicaid members within the area. And so we want to provide an allowance for those providers that build pharmacies or locate pharmacies in those particularly rural areas of the state that may have lower prescription volume. The second component of the tier scoring methodology is the Ohio Medicaid volume as a proportion of the pharmacy's total script volume. You'll also notice that this metric is the same metric that is utilized for the supplemental dispensing fee program that's currently operational. How this is operationalized is pharmacies are divided into thirds. So we arrange pharmacies by their proportion of Ohio Medicaid prescription volume, and then we divide them into thirds. The upper 1/3 of pharmacies will be allotted 6 points. The middle 1/3 of pharmacies will be allotted 4, and the lowest 1/3 will be allotted 2 points. You can see here on this slide the current cutoffs. Then these cutoffs are the percentage of Ohio Medicaid claims as a percentage of your total scripts. So you'll notice that the cutoffs occur at 11.5% and 23.2%. So what this means is that if you as a pharmacy provider are filling 30% of your claims that are Ohio Medicaid claims, you would be placed in the upper 1/3 tier, and you would be allotted 6 points for that. If you were a pharmacy that was filling perhaps 15% of Ohio Medicaid claims as a proportion of your total claims, you would be in the middle 1/3 and allotted 4 points. For both of these components, you'll notice there is a way to obtain 0 points. And the way to obtain 0 points is there is insufficient information to appropriately tier you. And typically that is because of cost of dispensing survey non-compliance. And so that would allot you 0 points. Your total score is simply component 1 and 2 added together. The minimum is 0, the maximum is 9. Also from this, you'll note that component 2, which is the Medicaid volume, is doubly weighted. So there are 6, 4, and 2 points as opposed to 1, 2, and 3 points. And that's really owing to the impact that we recognize, particularly for those pharmacies that have a very high Medicaid volume. We wanted to be sure to weight that appropriately and really account for the impacts on your business that can have. With that, we'll turn to the next slide, which will actually be how you obtain the automatic Tier C status. The automatic Tier C status, and Tier C will be the highest tier under the new program. There are 3 ways to get into Tier C automatically, and this is outside of the point values. The 3 ways are to A, have a specialty pharmacy designation from the State Board of Pharmacy roster. So we'll actually go out to the pharmacy roster and look at your pharmacy designation in that file. If it's listed as specialty pharmacy, you'll be placed in Tier C. We do understand that there are a lot of specialty pharmacies out there who do not have that designation. They may be designated, for example, as a mail order pharmacy. And so we wanted to make sure that we're able to capture the pharmacies that are truly the specialty pharmacies. So the second metric is pharmacies that dispense greater than 5% of their total medications that are ODM defined specialty medications. So in other words, that appear on the ODM specialty medication list. For those pharmacies that fill more than 5% of their total medications that are specialty, you'll also be placed into Tier C automatically. Lastly, for pharmacies that are statistical outliers with respect to Medicaid volume, and this is pharmacies that fill greater than 46.4%. Now that number seems rather random, but it's not random. It's actually greater than 2 times the upper tier cutoff on the point system. So the upper tier cutoff between the middle 1/3 of pharmacies and the upper 1/3 of pharmacies for component 2 is 23.2% this year. And so that doubled is 46.4%. So pharmacies that are filling more than 46.4% of Ohio Medicaid prescriptions as a percent of their total volume will also be placed in the highest tier under the program. This is indicated on the dispensing fee dashboard under the box of automatic Tier C, and it will equal yes. And that indicates that you've met one of the criteria here. You don't have to meet them all, you just have to meet one of them. And with that, we will turn to the next slide, which has your tier amounts on it. So again, 3-tier structure, tiers A, B, and C. Tier A is the lowest tier, Tier C is the highest. The tiers range from $7.64 per claim for Tier A, $8.75 per claim for Tier B, and $10.50 for Tier C. Again, Tier A, those are pharmacies that obtain less than or equal to 5 points per the tier scoring methodology. Tier B is for pharmacies that obtain 6 to 7 points under the tier scoring methodology. And Tier C is for pharmacies that obtain 8 to 9 points per the tier scoring methodology. Also, as we discussed before, there are ways to get into Tier A outside of the point scale, and that is for pharmacies where we don't have enough information to be able to tier, which again is generally due to cost of dispensing survey noncompliance. And then the automatic Tier C qualifiers are included on this chart as well. Next slide. In terms of specialty medication dispensing fees, pharmacies will be paid at their base rate on the previous slide, plus $46.25. And again, it's additive. So for example, if you're a specialty pharmacy, you are in Tier C under the model, you would be placed at the $10.50 tier. You'll achieve that in addition to the $46.25. So your total dispensing fee for that specialty medication would be $56.75. Again, this is only for medications that appear on the SPBM specialty medication list, and that is an add-on additional payment. For clotting factors, those pharmacies will be paid at their base rate plus $400, and again, additive. So if you're in Tier C as a pharmacy and you dispense clotting factor product, you would be paid $410.50 for that dispensation. The reason why that's so significantly higher is because these providers typically are lower volume providers. They don't dispense quite as many prescriptions. However, the prescriptions that they dispense are generally significantly more complex, as well as the fact that these providers have significant overhead costs. They have assay management costs, shipping and handling requirements, and accreditation requirements, as well as patient counseling requirements, which is why that number is as high as it is. Next slide. This is a recap slide. It kind of puts most of that information in one place, kind of easy to read. We've got both components of the tier scoring methodology on the left side. You equal the total points, and those total points will determine whether you are in Tier A, B, or C. We also have the specialty and clotting factor dispensing fees to the left side. Next slide. Some operational considerations around the dispensing fee, and these are kind of these will answer the logical questions that come from what we've just presented. So first of all, while we've presented the methodology, it could be very difficult for many providers to know exactly which tier they land in based upon that. And so for that reason, we are hosting a dashboard where providers can look up their tier by their NPI number. And owing to the complete and full transparency of the program, the pharmacies will be able to see your point totals for each of the metrics, your total point total, as well as whether you qualify for automatic Tier C status or not. In addition to that, you'll see your tier value, A, B, or C, as well as your dispensing fee amount under the new program. This is for the base dispensing fees, so we don't incorporate the specialty or clotting factor dispensing fees into the dashboard. This is just a way for providers to look up their base tier rate. We've provided the link, and this will be available on the Medicaid Managed Care site under the Single Pharmacy Benefit Manager Initiative. I'll show you a screenshot here in a few slides about where specifically on the page that will be located. Additionally, providers will be able to request redetermination of their tier at any time with justification. The department may ask for documentation that substantiates that justification. Those retiering requests should be submitted via email to Medicaid SPBM at medicaid.ohio.gov. The important thing to note here is that the Department of Medicaid will be the entity responsible for reviewing those redetermination requests and making a determination on those. It will not be the pharmacy benefit manager. That responsibility will be an in-house responsibility with the ODM pharmacy team. Another important note is that adjustments will be prospective. So we encourage providers to utilize the dashboard as soon as possible to look up your tier value. And if there's any disagreement with the data that you see in the dashboard, please bring that to our attention so that we can review the particulars of your case. The dashboard will be available at approximately 10 a.m. today at the conclusion of this webinar. Another important thing to note is that we will be doing scheduled annual redeterminations, and those will occur in the month of December, where we will reanalyze volume data as well as Ohio Medicaid encounter data. We'll recalculate those claims ratios and ensure that all providers are being placed in the appropriate tier based upon the scoring methodology. And so we're being very transparent with the scoring methodology. We want to be fair for all providers. So we want to ensure that we've got providers in the proper tier on at least an annual basis, and that we're reviewing those on an updated basis. Typically, those rates will have a January 1st effective date. New providers will be reimbursed at the Tier A, which is the lowest tier, until we have sufficient data available. Now, we do understand the unique impacts of what these rates would have on a new business in particular. And so in order for us to re-tier, we're only requiring 1 month of claims data, plus an attestation of the pharmacy's volume, as well as the percentage of members that are Ohio Medicaid. Again, we will be substantiating that with ODM encounter data, but that's an important note because we do want to quickly ensure for new providers in particular, we want to quickly ensure that they are appropriately tiered. So in other words, if we tier a new provider at Tier A, and after 1 month they have data that substantiates they should be placed in Tier C, we want to make sure that we can turn that around as quickly as possible because those funds can have a significant impact, particularly on new businesses. Again, it's important to note that when we make a change to the tier, they're prospective, not retrospective. Next slide. Some additional operational considerations, and really the emphasis for all of these is to be fair to all providers. So we are providing all providers with the rubric that we are used for grading. And so we want to make sure that we are transparent about what those criteria are and how you can meet them. It is important to note, though, that the dispensing fees may change as a result of those annual redetermination processes or cost of dispensing survey results. So if we see significant shifts with providers, that may result in a re-tiering. Again, this shouldn't be a surprise to providers because we're providing the rubric. So as far as total prescription volume or Ohio Medicaid proportion of claims, those are data points that are generally known to providers. Also, the tier scoring methodology cutoff values may change, and they generally do change slightly from year to year. Those are the cutoff values between the lowest 1/3, the middle 1/3, and upper 1/3 of all pharmacies. And that's really just owing to variations in Medicaid claims volume on an annual basis. So they may change slightly. So if they're 11.5% and 23.2% this year, next year they might be 11.4% and 23.1%. We don't anticipate wide swings in those. Generally, they move in a pretty tight range, but that's just another disclaimer that we want to put out there. Also important to note, the SPBM dispensing fees will have no impact on the supplemental dispensing fee program or the tier structure under that program. And so the payments that you're receiving on a quarterly basis, if you're a retail pharmacy, those will continue to be made through the end of that appropriation, which is state fiscal year 2023. Next slide. This is an example of the dispensing fee dashboard. And the dashboard is as simple as logging in, entering your NPI number and pressing the enter key, and then the results will populate. Next slide. And your results will populate. So you'll be able to see, did you meet the automatic Tier C criteria, what tier you're in, as well as the amount of the dispensing fee. And then we have a breakdown of scoring by components. So you'll see your component 1 score, your component 2 score, and your total points. This is labeled as NA because for those providers that are automatic Tier C providers, the scoring is not taken into consideration. That is an automatic classification into Tier C. Next slide. And as far as where to locate the dispensing fee dashboard, it is at the URL provided. So this is the Ohio Medicaid Managed Care Single Pharmacy Benefit Manager site. And it will be off to the right side under the For More Information. And you'll see a link that says SPBM Dispensing Fee Dashboard. Next slide. And with that, I will turn it over to AJ Summers, Senior Manager at Myers & Stauffer, for more detail on the Ohio Average Acquisition Cost Program.
Thank you, Sean. So we've had a lot of questions and concerns from providers come in over the OAAC in particular, what that looks like, how it's calculated, how it's maintained. So hopefully I can provide a little bit of clarity today on that and answer some questions and maybe alleviate some concerns. So to start off on program specifics, OAAC is calculated as the average acquisition cost based on the surveys of pharmacies enrolled in Ohio Medicaid. It does not adjust for off-invoice adjustments between pharmacies and manufacturers. It is reflective of the market conditions specific to Ohio pharmacies. It's recalculated semi-annually during the April and October OAAC survey processes. And those use March and September invoices respectively. In between those semi-annual survey processes, they are going to be updated routinely on a weekly basis based on changes in published pricing and market fluctuations. There is a provider help desk that will be available upon go live in October, but is currently available for general questions related to OAAC, and that's available Monday through Friday from 8 a.m. to 8 p.m. Eastern. And it is important to note that this is one of many state AAC programs that Myers & Stauffer administers, including the CMS NADAC. So it's nothing new. It's been around for a while. It's not a new concept. It is the average acquisition cost of Ohio pharmacies. So OAAC to date. So where we are at to date is we have conducted and completed the April 2022 survey. That included all enrolled pharmacies. And we were very pleased to see a 72% participation rate overall. So thank you for those out there who participated with submitting your data. That was very helpful. And you will see that in the draft OAC rates that we are going to post on the Myers & Stauffer website today, which I'll get into a little more specific on the next slide. The two main upcoming items for the OAC program are the implementation of the rates on SPBM Go Live in October, and those rates again will be monitored and adjusted in between now and that time frame for market changes and published pricing changes to make sure they're up to date. And then in October, we're going to start the October survey, which will include a representative sample of ODM pharmacies. Next slide, please. So as I mentioned, we are going to post the initial OAC rates, the draft rates that were calculated from the April survey. These will be posted to the Myers & Stauffer website at this URL, myersandstauffer.com/client-portal/Ohio. And the rate listings will be posted today, and they will be located under the Ohio Medicaid Pharmacy Pricing Information section on that website. We are posting the rates in an Excel file format for ease of use, and it will be at the national drug code level. And we're providing these for pharmacies to have the ability to review the rates, compare them to other pricing benchmarks, and use them for fiscal modeling purposes. So again, we're posting them as of today. And the important thing here is that these are reflective of March invoice cost. However, we have adjusted the rates based on changes in published pricing between March and today. So the rates will be adjusted. So what you're seeing is as of today, June 17th. So when you're looking at rates and you're doing comparisons to other benchmarks, such as AWP, NADAC, or WAC, make sure you're looking at those rates as of June 17th to ensure that you're doing an apples to apples comparison. Next slide, please. So the next thing I'm going to get into is the operational considerations of OAAC. I'm going to go through the help desk process, what that function exists for and how providers can best use that. And then I'm going to get into the routine weekly update and monitoring process of OAAC rates. So to start off for help desk, a high level overview of the help desk. It exists for providers to ask general questions on the OAAC program and reimbursement issues. You can reach out by phone at 800-591-1183, or you can email the help desk at ohpharmacy@mslc.com. And then beginning in October on SPBM Go Live, when the rates are live, providers can start to submit OAAC rate inquiries for review. This would be in instances where they want their costs to change significantly and the OAAC rate is questionable, and they want to have it looked at and reviewed for a potential rate update. So the way that providers will do this is they'll go onto our website, same exact URL. You'll be able to find a fillable form online, or we actually have an online form that you can fill out and submit directly, where you'll fill out the information on the drug and your cost. And then as well, you will attach your purchase invoices or copies of your invoices and purchase information and send that to the ohpharmacy@mslc.com email address. Once we receive your inquiry, we will send an acknowledgement of that inquiry within 24 hours. And then the review process itself will actually start once we've received all proper documentation. So it is important to make sure you fill out that form to completeness, and you do attach supporting documentation of your actual cost information to that inquiry. Next slide, please. So once the review process starts, what we'll do is we'll begin the review process and evaluate your costs against some of the following conditions. Is the cost inside or outside of the range of invoice cost used to set the current OAAC rate? Is the cost reflective of current market conditions? We look at availability, drug shortages, extreme pricing changes. Has the cost increased relative to prior costs received from the same provider or similar providers? Is there an alternative NDC available to the provider at a lower price? Are other providers experiencing the same purchasing limitations? And what is the provider's overall reimbursement on claim? And again, there's more criteria we can evaluate this against. It is a case-by-case basis. However, these are some of the most common criteria that we go through. So after the evaluation by a pharmacy technician, an analyst, and a pharmacist, if an OAAC rate adjustment is proposed, we will send that to ODM for final approval. Again, this is a 48-hour turnaround time, so the clock starts once we receive all that documentation from you. We review it, we get it sent to ODM for final approval, and then upon approval by ODM, we will transmit that updated OAAC rate to the SPBM for implementation in the system. And we will backdate those rates to cover the dispensing date that is included on the rate inquiry. So it's important that when you fill out your information, you put the right date, because that's something we've had in the past where the date was incorrect. We implemented the new rate and the provider had an issue with the effective date and their cost wasn't being covered. So we do ask to take your time and fill out those forms and provide all required information so we can do an adequate review. On the other end of the equation, if an OAAC rate update is not warranted, to the extent possible, Myers and Stauffer will work with the provider to provide alternative purchasing options that demonstrate product availability below the current OAAC rate. Again, OAAC is an average, so there will be winners and losers. We don't typically hear about the winners that providers have, so we only hear about the losers. So we do consider, or we do ask that providers consider their overall reimbursement and look at their entire book of business. Next slide, please. Another operational consideration and some questions we had coming in is how will OAAC rates be maintained between the semi-annual survey processes? So for brand OAAC rates, what we do on a weekly basis is we monitor changes to published pricing, WAC pricing, and if there's no WAC, AWP, and we adjust those OAAC rates based on the same % change in those published pricing benchmarks. This most commonly occurs on a large scale and every January and July. So once we receive that data from the drug compendia sources, we retroactively date those updated OAC rates as the same effective date of the actual pricing change. For generic OAC rates, Myers and Stauffer continually monitors these rates against market purchase conditions, and we adjust generic rates accordingly. We look for things like availability issues, significant price increases. And keep in mind, we do administer multiple state OAC programs in the NADAC, so we do continually have up-to-date intel on these purchasing conditions. So we do our best to keep these rates up to date and current with market conditions. But the most important thing to note here is that these rates are calculated directly from the costs submitted by you, the Ohio Medicaid pharmacy providers. So it is very important that you participate in the semi-annual surveys and you use the mechanisms in place to report changes to your acquisition costs, which include the provider or pharmacy help desk. And obviously, if you're feeling generous and you feel that we need updated information and you want to give it to us, we'll take it. Next slide, please. And to give a little bit of a more specific example of how the brand pricing update works, it's very similar to the NADAC pricing increase for brand prices. If you want to read a little further detail on how that process works, you can obtain the NADAC methodology on the CMS website. It outlines in detail how that process works. The OAAC adjustment process will work very similarly. So that can give you a good glimpse of how that works. But for this example, below here in the top, we have Vyvanse. We had a claim for Vyvanse on June 15th. This is before the WAC increase. And based on the lesser of all methodology, the pharmacy would be paid the NADAC rate, $1125,494. Obviously, all three rates are effective on January 1st, 2022. So on June 15th, that is the payment rate. Now we get a WAC increase that comes in on July 1st. It's effective July 1st. The pharmacy has the same claim, or the claim for the same product on July 15th after the WAC increase. As you can see in the bottom section, all three rates or price types have all been updated by the same 5% change, I believe is what it was. And based on the lesser of all methodology, they would be paid the $1181,769 NADAC rate using the lesser of all. Now, it's important to note that we are reliant on timely reporting of WAC increases to the drug compendia sources. There are lag times, and this is one of the most common complaints in the industry, but unfortunately, it's the nature of how things work right now. So we're at the mercy of the manufacturers reporting these prices in a timely manner. So there will be times where a pricing increase is reported by the manufacturer to the compendia. It's effective July 1st, but it doesn't get reported until July 5th, at which point the compendia get it, then we get it, then the SPBM gets the updated WAC price as well. And then the adjustments are made, OAC, NADAC, everybody. It gets implemented on July 7th. Well, obviously, between July 1st and July 7th, you're still getting paid the old rate. So what we tell providers to do in this situation is we do retroactively date these. Keep an eye on these, especially in July and January. And when you see these occurrences, give it a week or so and go back and rebill your claims and get your extra money. Next slide, please. And this last slide here on OAC, we just want to make providers aware on the same website, myersandstauffer.com, Client Portal, Ohio, we will be posting an FAQs for the OAC program, which will include answers to many of the questions listed on this slide. We will be maintaining that document, so as we have new questions come in, we will add those and add answers to that document. This document will be posted by the end of today as well. And with that, I'll kick it back to Sean.
Great, thanks AJ. At this point, we will turn things over to Dave Hartzell, Clinical Account Manager with Gainwell Technologies, for a brief overview of some contracting next steps.
Thank you, Sean, and good morning, everyone. So in relation to the contracting with Gainwell, I'd like to start with enrollment. So enrollment with ODMs required to be able to contract with Gainwell. If you need to update your information or start the enrollment process, the link to that is provided on the screen here in the first bullet point. Next, I'd like to give a high-level overview of the contracting process. First is consuming information about your pharmacies on an Excel spreadsheet that's been sent out. So pharmacies that are currently enrolled with the Department of Medicaid, we've sent out this Excel document and also a PDF of the contract for your review. So once we receive your information back, we then send out an executable contract through DocuSign. I do want to reiterate that we need the information from your pharmacy back as soon as possible, and that's really the first step. So if you've got questions about the process or the contract, or need to connect with Gainwell in any way, the email address and our phone number are both listed here, and we'd be happy to answer any questions that are out there around the process or the documentation. So Sean, back to you.
Okay, thanks, Dave. And at this time, we do have some time for questions. And so I'd like to turn things over to Stephen Alexander, the facilitator of today's session, to help facilitate the question and answer session.
Thanks, Sean. To update our frequently asked questions document. So on our website, we have a single PBM frequently asked questions document. We're going to update that to include both the latest information and also some of these new questions that have come in that we didn't have time to get to today. So in addition to getting a response in writing, you should also, look for the frequently asked questions document to be updated to address those questions. And then you can also, we've got the slide up right there where additional questions can come in through that dedicated inbox. So I've gone a little bit over time, but I think it was worth it to get to a few questions today. I know we've been meaning to do that for some time. There's just a lot of content in this space. So glad we could finally do that. And with that, I guess we will wrap up. Thank you so much, everyone, for participating today. And I'm sure we'll be continuing this dialogue going forward as we get closer to implementation. Thank you.